Our peptic ulcer disease, you know what is ulcer? So the ulcer is a disruption in the mucosa. It may be also in the skin. But so far peptic ulcer disease is concerned, it is a disruption in the integrity of the mucosa, and it should go up to the muscularis mucosa. And the size is more than 5 millimeter. Is it clear? Alright. So peptic ulcer disease is, the basic pathogenesis is increased secretion of hydrochloric acid in the stomach. Alright. Because of this increased secretions of the hydrochloric acid, ulcer may be in the stomach or in the duodenum. If it is in the stomach, we call it gastric ulcer. If it is in the duodenum, we call it duodenal ulcer. Alright? So, the ulcer also may be in the esophagus, also in some part of the ileum where Meckel's diverticulum is there. You will be knowing in anatomy, when we taught in the GIT, Meckel's diverticulum, where it is. Alright? Or the ulcer may be also, while we are a student like you, those days peptic ulcer disease surgical intervention is gastrojejurectomy. So there may be also ulcer, repeat ulcers in the jejunal part of the gastrojejurectomy. Alright, these are the few sites for your ulcer, peptic ulcer. So gastric ulcer is mostly in the lesser curvature of the stomach. This is not taught to you. Anatomy, abdomen is not taught to you. So suppose it is esophagus, this is stomach, this is greater curvature, this is lesser curvature, this is duodenum. So gastric ulcer is mostly in the lesser curvature of the stomach. Alright, I will show you in the slides. And duodenal ulcer in the bulk of the duodenum, that is in the anterior aspect of the duodenum. Okay? So how this physiology come? How this acid secretion occurs? How the acid secretion occurs? Acids are secreted from the parietal cell of the stomach. Alright? Suppose this is your gut, this is your interstitial space, interstitial fluid rather, this is gut. Come in. This is your parietal cells. Parietal cells are found mostly in the fundal area of the stomach and body of the stomach. Alright? So, this parietal cell has got your mechanism, fundamental mechanism to secrete insulin. You have to secrete your ACL. How it occurs? There are some pumps, hydrogen, potassium, ATPase pump. Alright. You know this is a cell. This H2O plus carbon dioxide, it will produce your HOCl and water, bicarbonated water. Alright, this bicarbonate will pass out, and this chloride will enter from the interstitial fluid. So this is your bicarbonate chloride exchanger. Alright, in the membrane of the parietal cells. Can you follow? Is it visible? Okay, fine. So this is the lumen of the stomach. So this chloride will, bicarbonate will go, chloride will go empty here, it will go there. Chloride, and this will be hypochlorous and hydrogen ion. Hydrogen ion will go up. So hydrogen ion and chloride will produce your hydrochloric acid. Alright, so this pump is hydrogen, potassium, ATPase pump. So this is the exchanger pump, and there is also sodium will go out, potassium will come, and there is also potassium will come out from the Cardinal cells. So this is your sodium, potassium, ATP pump. So these three pumps are involved in the synthesis of hydrochloric acid. Alright. So we'll go through the slides. Let us see. So what they say, peptic ulcer is a disease characterized by discontinuation of the inner lining of the gastrointestinal tract because of gastric acid secretion or pepsin. Ulcers are defined as, you note it down, ulcers are defined as breaks in the mucosal surface more than 5 mm in size. This also holds good in the ulcers of the skin with depth to the submucosa. It extends into the muscular proprial layer of the gastric epithelium. I will show you the histological slide of your stomach. It usually occurs in the stomach and proximal duodenum. It may involve the lower esophagus, distal duodenum or jejunum. That you know where the ulcer occurs. It may also involve, that I told you, epigastric pain is usually occurs in 15 to 30 minutes following a meal. So why the patient will come? Complaint is mostly pain in abdomen, in the upper part of the abdomen. You know the epigastrium. This is the epigastric regions. So this epigastric pain will be aggravated by food or it will be aggravated by hunger. Most of the gastric ulcers here will be aggravated by food. Alright. Duodenal ulcer, this is gastric ulcer. Duodenal ulcer, it will be aggravated by your fasting. It will be relieved by food. These are two characteristics. You follow? So you tell me, patient will feel discomfort after taking food. Suppose patient is suffering from an ulcer. Which type of ulcer this patient is likely to suffer from? Is it from gastric ulcer or duodenal ulcer? Gastric ulcer. Very good. Sit down. So, to the contrary, food will relieve the duodenal ulcer. Alright. Even the patient may get up in the early morning, pain, abdomen, hunger pain. So, it suffices that probably the patient is suffering from duodenal ulcer. This is a characteristic difference between the gastric ulcer and duodenal ulcer. On the other hand, the pain of duodenal ulcer tends to occur 2 to 3 hours after a meal. That means when the gastric occurs, patient feels hungry. Nowadays, testing for Helicobacter pylori is recommended in all patients of peptic ulcer disease. Commonest cause for gastric ulcer, pathogenesis is your increased hydrochloric acid secretion in the stomach, but commonest cause is H. pylori infections. Okay, what is H. pylori? H. pylori is ready to হবে না একটু সব মুছে যাবে clear out. Okay, fine, thank you. So H. pylori is a flagellate organism like this. Flagella is there. Okay, it is motile, gram negative. You will be knowing what is gram negative, gram positive in microbiology, and it has urease enzyme. Urease enzyme. What will do the urease enzyme? Urea is taught to you in biochemistry. Is it taught? Huh? Urea will be broken down into ammonia. This environment will be changed in the stomach. Alright. So, it causes the environmental changes in the stomach and helps in secretions of your hydrochloric acid in the stomach. It may so happen that there may be, Dr. Nag has taken a class on pernicious anemia, hypochlorhydria, achlorhydria. What is hypochlorhydria? Hypochlorhydria is less amount of acid secretion in the stomach, and achlorhydria is absence of hydrochloric acid in the stomach. There may be atrophy in the stomach. That may lead to anemia called pernicious anemia. Alright. This pernicious anemia is an autoimmune anemia. This anemia, anemic patients, pernicious anemic patient may have some other autoimmune disease along with that. Alright. Say type 1 diabetes mellitus. I am introducing the autoimmune. This is type 1 diabetes mellitus. Maybe thyroid problem, thyroiditis. May have also vitiligo. Alright. These are autoimmune diseases. So remember autoimmune diseases with relation to the pernicious anemia. Alright. This hyperchlorhydria, achlorhydria, and your so-called H. pylori infections. H. pylori infections also may convert your dietary nitrates. The nitrates is there. Okay, nitrates. This dietary nitrates is mutagenic. Mutagenic means some mutation may occur. Mutagenic nitrates that it may cause cancer even. Alright. So ulcer cancer. Ulcer may turn into cancer. Alright. There is also a terminology called Barrett esophagus. See that this is your esophagus, lower end of the esophagus. This epithelium is squamous epithelium. Squamous epithelium. It may so happen that because of laxity of your lower esophageal sphincter, there is a sphincter in the esophagus, so that the food content does not go up. Back. Otherwise, there may be laxity of the esophageal sphincter, so that the acid may regurgitate in the esophagus. It may so happen. Gastroesophageal reflux disease called reflux. R-E-F-L-U-X. Okay. So what will happen? Hydrochloric acid is reflux back into the esophagus, lower into the esophagus. So there may be some change in the squamous epithelial of your lower end of the esophagus. This will become columnar epithelium. You know what is columnar epithelium and squamous epithelium? We will gradually know. What is the characteristic of this conversion is called your Barrett esophagus. Alright? Is it clear? Barrett esophagus. You will be knowing later on. This Barrett esophagus is likely to have your changes to the cancer. This is a pre-cancerous state. Alright. So, this H. pylori and infection you have known now, by now. Nowadays, testing for H. pylori is recommended in all patients with peptic ulcer disease because it is commonest. Next is with NSAIDs, non-steroidal and anti-inflammatory drugs. Endoscopy may be required in some patients to confirm the diagnosis, especially in those patients have sinister symptoms. I told you what is the complaint of the patient. This will be epigastric pain, relieved by food or aggravated by food. Many times you cannot come to the conclusions. These symptoms you will get only 30 to 40% of the patients. Alright? The patient may have both gastric ulcer and duodenal ulcer as well. So you have to do some sort of investigations. Investigation of choice is your upper GI endoscopy. You will be knowing what is endoscopy. Upper GI endoscopy. Because of this patient may have some complication. I told you there may be your perforations, gastric perforations, duodenal ulcer perforations. Okay, the patient's diet will be less, so the patient may become anemic also. So blood count and anemia should be hemoglobin should be done in this patient. All right. Most patients can be managed with proton pump inhibitors based on quadruple drug therapy. This is for proton pump inhibitors. I have shown you the pump is hydrogen potassium ATPase pump. If you inhibit this, actually this hydrogen will be secretless. This is called proton pump inhibitors. In simple, it is known as PPI. Pharmacological name is omeprazole, pantoprazole. Okay. Another group of drug is there, H2 blocker. I will show you this histamine secretions from the endocrine cells of the stomach. There is histamine receptors in the parietal cells. It will also help to secrete more hydrochloric acid. So H2 blockers, trade name is your pharmacological name is ranitidine. One is H2 blockers, another is PPI. This is the fundamental mode of treatment for your peptic ulcer or duodenal ulcers, and also this has to be continued for a few weeks, maybe more in case of duodenal ulcers. For H. pylori treatment, you will require this drug PPI along with some antibiotics, maybe amoxicillin or clarithromycin, and metronidazole for a specific period. That will be taught in medicine. So, is it clear, the diagram? Can you see? This is your epithelial cells of the stomach. This is lamina propria, this is the mucous glands, and this is your muscularis mucosa. That means ulcer here should go up to the muscularis mucosa. Alright? And erosion will not go. Erosion will not. There is a called, if you do the endoscopy, endoscopists may write the ulcers in the laser curvature or in the duodenum, or may write this erosions. Erosions means it do not go up to the muscularis mucosa. Alright, there are three types of muscles in this stomach. One is your oblique muscle, then this is circular muscle, this is longitudinal muscles. Nerve supply of this stomach, there are two groups of nerve supply. One is your myenteric or Ayurvedic complex. Ayurvedic plexus or myenteric. This is also called myenteric. Another is Meissner's plexus. Myenteric plexus you will see in between this circular muscle and longitudinal muscles. Alright, this causes the motility of the stomach and intestines. Although intestine you will see this myenteric plexus. Alright, this Meissner's plexus you will see in the submucosa. This will be concerned with the secretions. So nervous, they have got a role. You know what are the phases of the stomach secretions? Proton, have you taught them? Gastric phase, intestinal phase, and nervous phase. Alright? You got the point? So the secretions, different phases I will show you. So you know the plexus. Anatomy will be taught, physiology teacher also will teach you this, what is the role of myenteric plexus and Meissner's plexus. Alright? So, phases of gastric secretions. One is cephalic secretions. Cephalic secretions. This means you will feel hungry. So, stomach will secrete these secretions. This is your cephalic secretions. And second phase is gastric secretions phase. You write it down. One is cephalic phase of the gastric secretions, gastric phase of the gastric secretions, and distal phase of the gastric secretions. Okay. Alright? That will be maybe asked to you in theory, also in Viva. So this slide shows again your circular muscle, longitudinal muscles, then gastric glands, muscularis mucosa, blood vessels of the stomach. So secretion of HCl that I have told you, you must be, can you tell me how this hydrochloric acid is secreted? Which cell secretes hydrochloric acid? Anybody? Yes? I have only introduced the parietal cells of the stomach. Parietal cells secretes hydrochloric acid. How it secretes? By stimulating, yes? By stimulating this hydrogen, potassium, ATPase, PAM. Alright? So it is shown here how it is secreted. Chloride and bicarbonate, it exchange between them. Alright, this is the pump. Hydrogen potassium is pump. Hydrochloric acid and chloride is coming through the exchanger. This bicarbonate after food is going to your intestinal lumen. This is called your alkaline tide. This is a defense mechanism for not having ulcers. Alright. Along with that, prostaglandin will also take part in your defense mechanism, the blood supply of the stomach. Okay. We also have in the role in the defense mechanism. So gastrin, you see that gastrin. Gastrin is secreted from G cells of the antral region of the stomach. Antral region of the stomach, G cells. Gastrin will have stimulatory effect on your hydrochloric acid secretions. Hypergastrinemia. There is a pathological term I will introduce to you, this Zollinger-Ellison syndrome. I will show you. Okay. So this vagal stimulation, this cephalic part, how it occurs, it will stimulate the secretion of acetylcholine. Acetylcholine. Have you come across the terminology acetylcholine in your MBBS career? Last 1 or 2 months? Is a parasympathetic. It comes from the vagal stimulations. Alright, hormones. And there is release of histamine from endochromatin cells of the stomach. And also stimulates the secretion of your gastrin releasing peptide. The gastrin I have told you is stimulatory effect, okay? And it will inhibit the somatostatin secretion from the D cells. So from D cells, somatostatin is secreted. What is the function of somatostatin? The function of somatostatin is to inhibit, remember this, to inhibit the secretion of hydrochloric acid from the stomach. So it may come into the MCQs. Somatostatin increases secretion of hydrochloric acid or somatostatin decreases the secretion of hydrochloric acid. So somatostatin will increase or decrease? Decrease. And gastrin will increase the secretions. So you've got 2 questions from MCQ. Alright. So this acetylcholine, what will do, it has got acts on the M3 masquerading receptors of the parietal cells. You may not remember this. Because of this stimulation of the vagus nerve, acetylcholine secretion, more secretions of the hydrochloric acid will occur. The mechanism you know. Alright. So also stimulation of secretion of your gastrin or releasing protein, secretion of the gastrin from the G cells of the antrum of the stomach, that will be increased secretion of hydrochloric acid from your parietal cell, and also it will increase the release of histamine from endochromatin cells of the stomach. So this gastrin will help to secrete and also will secrete more histamine. The histamine also will secrete, helps to stimulate the secretion of hydrochloric acid. Alright, so that's the role of H2 blockers. There are 2 groups. One is denatidine, another is proton pump inhibitors. So causes, you see that most important cause is H. pylori infections. Then followed by your NSAIDs. Other medications are there. Suppose we give steroids to some patients, corticosteroids. Okay. Some other drugs are also responsible apart from your NSAIDs. Rare causes are, this is Zollinger-Ellison syndrome. Alright, Zollinger-Ellison syndrome, that means your hypergastrinemia. Okay, this terminology you just know. This will be taught in biochemistry or even in physiology. Okay, so what will happen? Because hyperacidemia. Hydrochloric acid will be secreted more. Basal acid secretion is more. And gastrin level will be more than 1000 picogram per ml. So this is a diagnostic criteria for your Zollinger-Ellison syndrome. Very rarely it is seen. Diagnosis, you will give this pentagastrin or some sort of secretin. It's supposed to decrease the secretions, but output will be increased. injury relation syndrome. Alright, if it comes as short note, it's unlikely to come at MBBS level. Just remember that hypergastrinемia is there. If you give secreting, the more hydrochloric acid will be secreted. Alright. Then there are certain viral infections. Cytomegalovirus, herpes simplex infection is there. That may also increase. This is important. You may have to know this cytomegalovirus and herpes simplex. In times to come, radiation therapy, Crohn's disease, some chemotherapy, and reasonably infiltrations. This will be gradually will be knowing. These are the rare causes for your peptic ulcer. So, H. pylori associated peptic ulcer disease. H. pylori is a gram-negative bacilli that I have shown you is found within the gastric epithelial cells. This bacterium is responsible 90% of the duodenal ulcer and 70% to 90% of the gastric ulcer. So mostly it causes duodenal ulcer. It may have some role in the gastric ulcer. H. pylori infection is more prevalent among those with lower socioeconomic status and is commonly occurred during childhood. So in the developing countries, this infection is more. In the developed country, it is comparatively less. The organism has wide spectrum of virulence factors allowing it to adhere and inflame the gastric mucosa. This result in hypochlorhydria or achlorhydria leading to gastric ulcerations. That I told you. How this achlorhydria, I told you the cancer part, mutagenic nitrate. How this hypochlorhydria or achlorhydria will cause gastric ulcerations? Because of this hypochlorhydria or achlorhydria, other bacteria may grow into the stomach. There will be more growth of the H. pylori. Also, there will be more inflammations and some other your interleukins will be secreted more and will cause the gastric ulcer. Examiner may ask you, if you utter this hypochlorhydria or achlorhydria causing gastric ulcers. Less secretion of hydrochloric acid, how it causes gastric ulcerations. The dietary nitrates will be converted into mutagenic nitrates. Alright. So virulence, urea test you can do. You can do the toxins. Flagella provides motility and allows movement toward the gastric epithelial. Some tests you have to do. Urea test, urea breath test, stool antigen test, urine antigen test. Okay, you can do for identification of H. pylori infections. Once it is identified, you have to eradicate. Otherwise, treatment is incomplete. All right. The treatment part also I told you. What are the drugs you are supposed to give in the H. pylori infections? The H. pylori infection, if it is detected, how you treat the patient? You will give the PPI. You will give more antibiotic, either amoxicillin or clarithromycin. You know this in pharmacology, also metronidazole for a certain period of time, maybe for 2 weeks, 3 weeks. Alright, remember this. Medications, apart from your NSAIDs, certain drugs, corticosteroid, I have told you that biphosphonates. Sir is sitting here, he is writing the biphosphonates. Okay, alright, you will be knowing this. What are the other drugs may cause? Corticosteroid you remember, NSAID you remember. Alright. What is the epidemiology? How many people are suffering from peptic ulcer disease in the society? You see that it is not that uncommon. It is near about your 5 to 10% lifetime suffering, the global problem, not only in India. It is not that uncommon. 5 to 10%. 5 to 10% is your quite high. It is global prevalence. Global prevalence. You know the prevalence. How many patients are suffering? Incidence means new onset of the disease. Okay, in epidemiology, what it comes? Agent, host, and environment. Agent, host, and environment in epidemiology. Try. Okay, that will be taught to you in community medicine. What is the agent? Agent is H. pylori here. Most of the cases you will get the H. pylori 70 to 90%. Host is human being. What is the environment? Environment and milieu of the stomach. Alright, but the defense mechanism is good or defense mechanism is not adequate to defend the patient from having ulcerations. Alright, this is the agent, host, and environment. So you know now, by now, all right? Take care. So 5 to 10%. There is also recurrence. Once you treat, the patient may have also recurrent peptic ulcer, duodenal ulcer. Most important factor of recurrence is, apart from the NSAID, is if the patient smokes. Smoking. Alcohol also has got a deleterious effect in causations of your peptic ulcers. Alright, alcohol and smoking, you have to remember this. Overall decrease in the incidence of UD worldwide due to improved hygienic and sanitary conditions combined with effective treatment and judicious use of NSAIDs. How will prevent this? Prevention is sanitary, so that improvement, so that the infection does not occur. Especially infection does not occur among the people. Also, the hygienic way and effective and judicious use of NSAIDs. What is this NSAIDs? Non-steroidal anti-inflammatory drugs. Example is brufen, ibuprofen. Nimuselide, of course, nowadays is withdrawn from the market. Alright, patient having the headache and all, they will take the medicine. Apart from this NSAIDs, aspirin, acetyl salicylic acid. Most of the time we prescribe to prevent this cardiovascular disease or stroke also, aspirin. Aspirin also may have a causations for your ulcerations. Alright? Aspirin, acetyl salicylic acid. Alright, duodenal ulcers are 4 times more common than gastric ulcers. Duodenal ulcers occurs in the young people. Gastric ulcer, little bit elderly people, say 50 years and above. So duodenal ulcer is more common. So which ulcer is more common? The MCQ questions is duodenal ulcer. Remember this. Where the duodenal ulcer occurs? In the duodenum. Yes, I told you. In the anterior aspect of the first part of the duodenum. Alright, you remember this. So, pathophysiology, you know how it causes the increased secretion of the hydrochloric acid, and if there is background in the family, also it has got an effect. Okay. So, how will you prevent this? Sir is asking for your prevention. How will you prevent this? Prevention is judicious use of NSAIDs. You should not, the common people should not take NSAIDs without the proper prescription of a registered practitioner. Okay, their sanitation should be improved, hygiene should be improved, alright, so that there is less. Why this should be improved? So that there is less your H. pylori infestations. Alright, H. pylori, what is H. pylori? Yes, diagram of the flagella, motile, gram-negative bacteria. Okay. So this is the role of preventions. And once it is there, you have to take some medications. Alright, you should not have your empty stomach for a long time. Then 2 other factors I told you. One is smoking, another is alcohol. Smoking should be prohibited. Alcohol intake should be in moderation as per foreign book, but our continent, our state, we tell that don't drink alcohol. Don't drink alcohol. Alcohol is forbidden. Okay. So this will take part in prevention of your occurrence of peptic ulcer. This slide shows, it will be taught in physiology or biochemistry, I don't know. This is your defense mechanism. Mucosa, alkaline tide, blood supply, this is the nervous system. I told you this. What is the nervous supply of the stomach? Motility. Ayurvedic plexus I have shown you. Ayurvedic plexus, motility. And for secretion is Meissner plexus in the submucosa. What is Ayurvedic plexus there? In between the sacral muscle and longitudinal muscle. You have to know this. This may come in the MCQ also. Alright, clear? I've shown you, no? Is it clear to you now? So this is a defense mechanism so that it does not occur. So defense mechanism also takes a part in prevention of your gastric ulcerations or duodenal ulcerations. If defense mechanism is weak, naturally this will occur. Alright. After food, this bicarbonate is going inside. No, more bicarbonate. This is alkaline type. It will reciprocate with chloride. Bicarbonate will come out from the paradise cell. Chloride will go inside the paradise cell to produce HCl. Okay. So I just did this. Defense and repair. Under normal conditions, mucosal integrity is maintained by defense mechanism, which include pre-epithelial factors, mucus bicarbonate, phospholipid barrier, and epithelial barrier, surface epithelial cells connected tight junctions and generating bicarbonate mucus, phospholipids, and triple peptides. Alright, triple peptides. So once the defense mechanism is strong, ulceration will not occur. Alright. Pathophysiology, you know that peptic ulcer will go when the ulcer difference. What is the difference between ulcer and erosions? Yes, you tell me. What is the difference between ulcer and erosions? Ulcer is more than 5 millimeter and it will extend to the muscularis mucosa, whereas erosions will not go to the level of muscularis mucosa. Every word is important. Alright?
Normal theory.
Histopathology, this is this, yeah? Ulcer extends beyond the muscularis mucosa. Remember this. Common signs of symptoms. There is the most important part of early clinical exposures. Epigastric abdominal pain. And 20% of the patient may have pain on the right side of the abdomen. Pain in the right side of the abdomen in our state, probably commonest cause is your cholecystitis. Okay, inflammations of the gallbladder. There may be stone in the gallbladder, cholelithiasis. So we differentiate it, whether it is because of the peptic ulcer or because of your cholecystitis. The patient may have bloating sensations. Alright, abdominal fullness, nausea, vomiting. There may be weight loss or weight gain. Weight loss. Why weight loss? Because the patient of this pain, gastric ulcer is aggravated by the food intake. Naturally, they will afraid of taking food. So, they will lose the weight. Or, to the contrary, the patient may have some malignant changes. Malignancy is also one of the important causes for your loss of weight. To the contrary, weight gain. Why certain patients of your peptic ulcer will have weight gain? Duodenal ulcer, I told you, it is relieved by food. Even in the midnight, early morning, the patient may wake up from the sleep because of the hunger pain. So they will take food. More food, weight gain. Alright, so this is the easiest way of explaining this. The patient may have hematemesis. What is hematemesis? Vomiting out of the blood. This may be fresh blood or your tarry red blood because of your action of this blood with hydrochloric acid. This may not be fresh blood because of ulcerations. And one of the common cause of hematemesis in our state, in Manipur, northeastern region, it is because of ruptures of the oesophageal varix. Oesophageal varix, what is the pathogenesis? It is because of cirrhosis of the liver. So you'll be knowing the sympathetic and your portal venous connections. Okay, because this varix is because of these connections in the lower part of the esophagus, there will be distension, dilatations, and vomiting may also rupture this varix. Alright, this is hematemesis. Melena. What is melena? Melena is your black stool, black foul smelling stool. This is because of your bleeding in this upper part of the intestine. That is maybe because of the gastric ulcer or the rupture of the varix, variceal bleeding. It will go down and there will be actions. What is foul smelling? The black stool. It will not be red. or diarrhea, okay, black stool and foul smelling because of this blood has to pass through the intestine, some bacteria will act upon this. You do some test for melena. Alright. Then cardboard-like rigidity and obliteration of the liver dullness. Okay, so I told you this cardboard-like rigidity and obliteration of the liver dullness. Liver dullness is there. Okay, from the fifth intercostal space, will come down. Okay, so this will be obliterated, dullness will be obliterated. Cardboard-like rigidity and your liver dullness, perforations. And succussion flash in your gastric outlet obstructions. Succussion flash means you put a stethoscope, shake the patient, there will be some gurgling sound you will listen. This is because of your gastric outlet obstructions. So gastric outlet obstructions, hematemesis, melena, these all constitute your complications of your peptic ulcer disease. Alright? Then cancer is of course one of them. So warning signs, unintentional weight loss. What is the warning sign? Why the patient very much? Patient should be taken very seriously when there is unintentional weight loss, progressive dysphagia, overt gastrointestinal bleeding, reduced hematemesis, iron deficiency anemia. Some of the patients may not have any complaint. Routine investigation just see the iron deficiency anemia. Anemia is there. You need to find out iron deficiency anemia. What will happen in the microscopic picture of iron deficiency anemia? This is microcytic and hypochromic. We have taken class on iron deficiency anemia. Alright. So you have to think for the patient is suffering from your peptic ulcer disease. Recurrent emesis. What is emesis? Vomiting. Repeated vomiting. Okay, because of irritations. Family history of upper GI malignancy. If it is there, you have to be taken very seriously. So how will you evaluate? History you have to take. In history, what will you see? The pain abdomen, or any docketing, or the side, any aggravating factor, any relieving factor is there or not. Any history of vomiting, any history of your vomiting of the blood, or any history of melena, weight loss. This will incorporate in your history. Have you evaluate this? Investigation, you have to do this H. pylori, I have told you. Then your, okay, warning sign you know, evaluation you know, investigation also you know. This is your 2 gastric ulcers. Okay, this is gastric ulcers. Multiple gastric ulcers. This is your antral gastritis. Thus I have taken from the net to show you. Okay, this will see in the endoscope. So H. pylori testing, what we'll do, you know by now, antigen test, stool antigen, urine antigen, and also antibody and urease test. Okay, differential diagnosis. One of the differential diagnosis, pain abdomen, so I told that myocardial infarctions, pancreatitis, pancreas inflammations, pancreatitis may have also pain. And then radiate back, this your gallbladder stones, pain will be relieved by vomiting. This pancreatic inflammations, pancreatitis, it is not that very uncommon. Alcohol is also a predisposing factor for peptic ulcer, I told you. The vomiting will be there, but it will not relieve the pain. And the pain, this pain in the pancreatitis will be referred to the back, and it will be relieved by you stooping forward, the patients. Alright. So myocardial infarction also is important differential diagnosis for your pain in the epigastric regions. Biliary colic, gastric cancer, life-threatening differential diagnosis is your myocardial infarctions. Okay, what is myocardial infarctions? The blood supply to the myocardium is jeopardized. Pain is there more than 30 minutes. There will be some biomarkers you will be knowing later on. Mesenteric ischemia, mesenteric vessels in the abdomen. There will be ischemia there, pain abdomen will be. These life-threatening conditions. So these are the life-threatening conditions, differential diagnosis of your epigastric pain. There may be mesenteric vasculitis also. It's just 2 terms, vasculitis, mesenteric ischemia and myocardial ischemias. We introduced to you, try to remember this, you'll be knowing more in your subsequent semesters. Prognosis, unfortunately recurrence common, rates exceeding more than 60% in most series. So recurrence is more. Prognosis means whether the patient is getting cured, whether lifetime recurrence is there or not. Okay, patient is improved. Okay, mortality may be there, maybe because of the cancers. If the patient is suffering from your myocardial infections, there will be prognosis will be guarded. Also in the mesenteric ischemia and mesenteric vasculitis. So outcome of the disease process. This prognosis. Say, as for example, I will give you an example. In the beginning classes, foundation course classes, I told you, patient comes with ascites, edema, suffering from cirrhosis of the liver. Okay, this is called decompensated cirrhosis of the liver. In the other context, I am explaining this. So many times we ask the students, what is the prognosis of this case? Student will answer, prognosis is bad. Obviously it is bad. How bad it is? I told you in the foundation course also, 25% of this decompensated cirrhosis of the liver does not live beyond 2 years. That means 1/4 of the patient will die within 2 years. This is bad prognosis. So in contrary to the your peptic ulcer, the recurrence rate is quite high, and this perforation also is your 0.3 patient per year. NSAID is related perforation. This is drug induced. This is very bad. If drug induced, gastric ulcer is there, perforation is there, prognosis is very bad. Alright, outcome. However, unlike in the past, mortality rates of peptic ulcer disease have decreased significantly because nowadays perforation comes very rarely because of your treatment with PPI or H2 blockers. Alright, surgical intervention also does not become so important. So frequently, the complications are upper GI bleeding, gastric outlet obstructions, perforation, penetration, gastric cancers. So these are the complications of peptic ulcer disease. Medical treatment, I told you. Less tea, less coffee, no alcohol, no smoking. Bland diet, no spicy food. Okay, you give PPI or H2 blockers for a certain period of time, maybe for 12 weeks. Alright, if not any cases, may will require your surgery. Some of the patients may not respond to your treatment. The terminology is refractory. Optimal period of time you put the patients on H2 blockers or PPI, the patient is following your diet, not taking alcohol, not smoking, even though patient symptoms are not relieved. This is called refractory. Alright, not amenable to medical treatment. This may require surgery. Different surgical procedures are performed in these patients. Okay, right?